I'd like to start off first by acknowledging the traditional owners of the land, the Wurundjeri people of the Kulin Nation, where we're meeting today. A lot of us, or a few of us, would have had the opportunity to hear Professor Alex Brown speak here at WEHI last year, and he gave quite an exciting and intriguing talk, and so I'm very much looking forward to his talk today. So just to give you a little bit of background about Alex, he has lots of letters to his name. He's the Deputy Director of the South Australian Health and Medical Research Institute, or SAHMRI, as many of us know that as. Besides his medical degrees, he also has a PhD and a Master's in Public Health. He has an extensive experience in working with communities, both rural and local, and a number of connections to not only government but NGO organisations. Impressively, he is also the lead investigator in over $8 million worth of research funding over the last 5 years. And essentially, he does what is very impressive to do as an Indigenous doctor and Indigenous researcher, but he is able to span both the areas of Indigenous as well as Western medicine's knowledge and thinking. And so it's with great excitement I invite Alex Brown to the stage. Thank you very much.
Well, thank you. It's good to be here a year after the last time. I think we were waiting for grants last time around as well, so I hope you all do extremely well. It's a tough 5 years ahead, so hopefully we don't take it all too personally and push on. Look, today I probably thought I'd take the next step in this sort of what I hope will be a yearly journey together. Last time around I spoke about some of the issues facing Aboriginal people and Aboriginal health. Today I'll try and raise, unfortunately, very few answers, but a whole range of questions that I think the premier medical research institute in this country should have a role to play in. We'll work through this together. Certainly is a great honour to be here and fantastic to be given this opportunity to have a conversation. So what do we know about the world's Indigenous people? Well, there's bucket loads of them. It's very easy to think that Indigenous people in this country are a very small proportion of the population and really fulfil a very small niche within the political landscape of this country. But Indigenous people the world over make up an enormous part of the global community. We know there's at least 400 million Indigenous peoples spread across 90 countries. They have all experienced varying degrees of conflict, of cooperation, of conquest throughout time, and depopulation experiences. But there are fundamental things that tie us together as the world's Indigenous peoples, and unfortunately most of the things that tie us together are not very nice. They are a shared history of discrimination, of marginalisation from the political and economic development that we've seen across many countries in the world. And we do also know that Indigenous peoples the world over are overrepresented in poor outcomes. They're more likely to be impoverished, get poor educational outcomes. They're more likely to be exposed to the judicial system and incarcerated. They're more likely to experience degradation of their environments, of their lands, of their homes, and they've been dispossessed from their place. These are important contextual factors, not to wring out a whole raft of things that Indigenous peoples complain about. But when trying to understand the health and well-being of populations, it's extremely important to understand context. And this is a very important part of the narrative for Indigenous peoples the world over, that these demonstrations from member states of their disregard for vulnerable communities has a long-lasting impact and effect. The challenge we also face in Australia is we haven't really come to terms with what an average Aboriginal person might be. Are they a sports person? Are they a painter? Are they an academic? Are they a lawman or woman? Are they kids? Certainly the largest proportion of the Aboriginal population are under the age of 18. Are they activists? Are they grandparents? Or are they just parents? The fundamental reality is Aboriginal Australians are all of these things, and often all of these things at once. We are more than just really good people to have at an opening ceremony. We're also very good people to have around when thinking about the things that society has lost. This sense of connectedness, this sense of understanding how to care for the world around us. Aboriginal people have a very important role to play in modern Australia. Unfortunately, we still are locked into a vision of what Aboriginal people are and should be rather than what they are and must be for all of us to gain a better future. In fact, we struggle with what Australian mainstream's vision for Australia is and its vision for what Aboriginal Australia can offer. So the question is, if only we understood what Aboriginal people can offer the world, we may have a chance of saving the damn thing. Anyway, we'll get to that. What do we know about Aboriginal people? This is data from South Australia, and there are, in fact, some horrible statistics in this slide, but some room for optimism. If you look at the year I was born, 1971, the population pyramid in the dark black here for Aboriginal people in South Australia was pretty ordinary. Extremely high mortality, a very narrow, very pointy-ended population structure, very few people making it past the age of 60. There have been significant changes over time. There is blossoming of this middle and young age coming through, and for the first time in many years, we're starting to see the growth of the over 75 age group in Aboriginal Australia. This is something to celebrate. Who would have thought that this is really something that is that wonderful? For somebody who counts mortality statistics, this is a wonderful, wonderful outcome. But the reality is there are still enormous concerns at play. Aboriginal people are much more likely to die in these middle ages. Their median age of death is still much lower than non-Aboriginal Australians, particularly when you look at the comparison between these. This is fundamentally our national key performance indicator when it comes to Aboriginal health. We have such high mortality in middle age in Aboriginal people. We can't grow up elders. These elders can't grow up their kids and grandkids. We can't maintain our connection to the past. Communities suffer, our future suffers. So we have a fundamental obligation to make sure that the age of death that we see in Aboriginal and Torres Strait Islander Australians changes rapidly so that we can start to see a pattern that is dominated by the aged rather than the loss of people in their prime. So is there any improvements on that front? Well, there's a little bit. Again, this is data from South Australia. These are rolling averages, so it looks like we counted the same year over and over and over again. But fundamentally, there has been roughly a 10-year increase in the median age of death for Aboriginal South Australians over the past 20 years. This is good, but fundamentally, we still have a massive gap between Aboriginal and non-Aboriginal Australians. Non-Aboriginal Australians have had similar, although not quite as significant, rises in the median age of death. Already over 75, I reckon you guys are being greedy. You should give some back. But that's another thought. So why do we think that Aboriginal people can make a difference to the future? Well, there's a few grand challenges we face as society, as a nation and as a global community in terms of health and wellbeing into the future. The first is non-communicable chronic diseases, and fortunately our poster boy here, Homo sapien, is leading the charge in the wrong direction. What do we know about non-communicable diseases? This is data published in The Lancet a little while ago, a series really focusing on the global impact of non-communicable diseases. And you can see here one wonderful shining light and another four of grave concern. See here for infectious diseases, significant improvement over time, in terms of the likely impact on global death rates, but rises in coronary heart disease, diabetes, other chronic conditions, cancer, stroke, and other chronic respiratory diseases. So it is likely that the future, in terms of the major burden of disease suffered by all people across the globe, are going to be non-communicable diseases. In 2005, they accounted for 2/3 of all death, and the vast majority of these were in communities and countries without the resources to actually mount a response. There is clearly a bidirectional relationship with poverty and NCDs. This is something we have not tackled as a nation nor as a global community. We have lost, and only now a government starting to realise that if we don't get on top of chronic diseases, it has direct productivity issues for us as countries. And for example, if you look at Cameroon, the treatment of one patient with type 2 diabetes is 50 times the current per capita health spend in that country. These are enormous challenges to face moving forward. What do we see in Australia? Well, if you look at the gap between Indigenous and non-Indigenous Australians, the likely scenario is that the gap will widen over the next 20 years. There have been some improvements in mortality for Aboriginal people, but we are losing ground when compared to non-Indigenous Australians. The gap is widening, irrespective of all the benefits that we've seen delivered over the last 5 years. We still see enormous rates of diabetes. This is type 2 diabetes in Aboriginal and Torres Strait Islander people compared to non-Aboriginal Australians. These are massive rates, these are massive differences, and we're starting to see for the first time in the last 5 years the growth of diagnoses of type 2 diabetes in Aboriginal children. When I was leaving Alice Springs a couple of years ago, we were diagnosing kids as young as 10. If we see what is seen in Canada currently, where they're dialysing Aboriginal youth in their late teens because of end-stage renal disease as a consequence of diabetes, we would have lost the race. We haven't seen that in Australia yet, but I fear that it's not too far away. But it's not just the burden of diabetes as a prevalent condition that matters. There are enormous disparities in outcomes. So Aboriginal people are more likely to have diabetes, but they're also more likely to die from it. And this data, comparing other jurisdictions and other Indigenous populations compared to mainstream populations in their countries, even though there is a higher prevalence of type 2 diabetes in both the US and Canada in First Nations and American Indian populations, their mortality is not that different. I mean, it's certainly more significant than they would like. But then you see good old Australia here leading the table and having 8-fold mortality for Aboriginal people diagnosed with type 2 diabetes. So this is like for like. This is not just saying Aboriginal people are more likely to die. This is Aboriginal diabetics are 8 times more likely to die than non-Aboriginal diabetics in this country. We are fundamentally failing in our obligations. And what's part of that story? Well, our health systems aren't necessarily doing their job. We're not stopping people with diabetes from smoking. We're not protecting their kidneys well enough. This is measured by markers of urinary or renal function. We're not treating their dyslipidemia particularly well. We're not hitting targets around therapy for controlling their blood sugar in the short term or the long term. Our healthcare system has a long way to go. And as a consequence, we're starting to see increasingly evident disparities and ongoing rise in end-stage renal disease. This is almost a key indicator of how well we're doing in our fight against type 2 diabetes in Aboriginal communities. In both Australia and New Zealand, we're not doing anywhere near as well as we would like. We're certainly not doing anywhere near as well as we need. But emerging, this story of cancer is starting to play out. Now, 10 years ago, we would always talk about the fact that Aboriginal people were less likely to die from cancer than everyone else. This was largely because they never lived long enough to be fortunate enough to die from cancer. This is changing. You can see here higher rates of the incidence of cancer. There's particularly lung cancer here, as you would expect, in a community that has 50% smoking rates. Not enormous difference in terms of incidence across the board. But for virtually every condition here, and this is New South Wales health data, Aboriginal people are much likely to die when they have a diagnosis of cancer. So there are enormous disparities in both the onset of disease, but there are also much worse outcomes. This is repeated in new data that we've just analysed coming out of South Australia. This is courtesy of David Roeder and colleagues. You can see both the massive increase in the number of Aboriginal people diagnosed with cancer over these periods of time. This is a massive increase of almost 4-fold. But unfortunately, no change in survival. No change in survival for cancer for Aboriginal people over 30 years. This is clearly problematic. And you would expect to see at these time points at least some improvement in survival rates, as we've seen in non-Indigenous Australians for most cancers. That leads us to how, in God's name, we're going to overcome intergenerational disadvantage. Well, Reg has an idea. We'll just try and get white people to live a bit less. Highly unlikely to fly. So let's just move on. What do we know about where things begin? Infant mortality rates. Pretty easy population health rubric to understand. It's the number of kids who die in the first year of life, really. And you can see significant improvements over time for Aboriginal and Torres Strait Islander people across a number of jurisdictions. Again, 3-year rolling averages here, just to get some stability in the numbers, because there are small numbers of Aboriginal people when it comes to vital statistics, but improvements in most jurisdictions over time, but ongoing improvement in non-Indigenous infant mortality rates. What these sort of data hide is the disparities we see within various jurisdictions. You can see in New South Wales, not a big difference between Aboriginal kids in terms of their rates of mortality and mainstream non-Aboriginal kids. In most other jurisdictions, very large gaps, particularly the Northern Territory. But we also see within jurisdictions significant differences in infant mortality defined by geographical location. Here in South Australian data, remote kids in the top end of South Australia, right up at the border, these kids have extremely high infant mortality. There are disparities within disparities within disparities in this country, and we haven't mounted a response, whether that be from a healthcare system, from a policy, or from a social determinants lens. What do we know about these kids? These kids start to colonise with bacteria extremely early in their life. This is data from the Northern Territory following 2 remote communities. These are kids about the age of 2. Extremely high rates of carriage over time and very persistently. This is comparing to some kids in Alaska, some American Indian populations. You could say, well, maybe these are just commensals, they're hanging out there because they're nice bacteria. Well, they're not nice bacteria. The rates of resistance in these particular isolates is extremely high, between 50 and 80%. These kids are colonised early, pretty much from day one of their life, and these are pathogenic organisms that carry an enormous impact down the chain in terms of inflammatory burden, but also direct pathology. This same bit of data really looked at, the same study by Hare and colleagues in Menzies School of Health Research in Darwin, looked at a range of reasons why these Aboriginal kids were presenting to primary care. Just draw your attention to the median number of presentations over this window period. The kids for a range of upper respiratory tract infections, the median number of presentations in 2 years was 7.5. Scabies 3 times. This is an enormous inflammatory burden carried by these children right from day one. And importantly, if you look at rates of scabies acquisition, this orange bar here is first infection. The cumulative incidence of scabies in these kids from day one, by the age of 24 months, about 70% of these kids had scabies. This is enormously problematic. This is establishing a potentially problematic milieu, and we don't have the system to respond. We also know that these socially determined infectious disease burdens are important in terms of rheumatic heart disease, extremely high rates of RHD in Aboriginal kids right across the country, particularly across the top end, and invasive pneumococcal disease rates, extremely high. And in fact, if you look at this data here, published from Australian enhanced surveillance data, this is post the introduction of a range of polyvalent vaccines for invasive pneumococcal disease, and we're really not capturing any response in any way, shape or form. Why does this matter? Well, there are a whole range of things. Disadvantage begets disadvantage. This is data from the US showing that in terms of maternal health and behaviour, pre-pregnancy, in disadvantaged compared to advantaged populations, things are much worse if you're disadvantaged. You're more likely to smoke before pregnancy, you're more likely to have diabetes or hypertension, you're more likely to be obese. These have important ramifications for the next generation, and we are not responding anywhere near as well as we need to. This is important because the intergenerational cycles of type 2 diabetes are now, I would say, firmly established from the epidemiological sense. This is data from Pima Indians, work by US colleagues who have really been able to track these children born to mothers who had type 2 diabetes during pregnancy. What they found in this first generation offspring, 70 to 80% of these kids had type 2 diabetes by the age of 30. There has now been significantly more data looking at the next generation, that is the kids born to the kids of the mothers with type 2 diabetes during pregnancy, and 80% of those second generation kids have type 2 diabetes by the age of 19. These intergenerational cycles must be broken, and we're not doing anywhere near enough. We know this is important because if you're exposed to a tough childhood, your chances of having future chronic disease is extremely high. This is data from the US, looking at 40,000 adults who were exposed to a raft of different adverse events in their childhood. They were exposed to a whole range of adverse events as children. When they were adults, they were more likely to be depressed, more likely to be obese, and more likely to smoke. There is a context behind the way in which we behave in the future. Our risk is determined, and we have a system that focuses on chronic disease being delivered as a consequence of people's bad behaviour and bad choices. There is a much bigger story at play. Clearly, understanding socioeconomic status in childhood and a range of disadvantages is important to create public policy that will make a difference for the future. It's important because there are physical environmental exposures that are predetermined or laid out as a consequence of your social strata. There are a range of mechanisms at play, and these have important consequences in terms of adult health. We have not taken the next step from observational epidemiology to interventions that make a difference over the generations. This is the fundamental challenge that I pose to us today, and hopefully an important starting point would be in understanding disadvantage in an Aboriginal way. The other thing we know is if you start in a poor space, if you're an Indigenous minority, you're more likely to stay there. This is data from the US, suggests if you grew up in a poor neighbourhood, your chances of leaving that neighbourhood to get a better future for you and your next generation is much harder to get out if you're black compared to white in the US. Similarly, if you start well, you're less likely to stay there if you're black compared to white. These are important disparities that play out on the social front. Similarly, we know educational outcomes for Aboriginal children in this country are appalling. This is data from South Australia that would suggest after the age of year 10, there are enormous disparities rising within geographical locations within the state. It would suggest that over the age of also the chances of year 11 or year 12 completion through high school is extremely or much lower if you come from a remote community. We have not created an educational system in this country that decreases disparity between populations. What's our other grand challenge? How do we overcome this inequality? If you look at data from the US, you guys would know this. This has been a very important part of lots of narratives from the left-leaning world. The people at the top chew up the most. This is very clear. Even our good friend Monty Burns, he's quite proud of it, but others are not. We know in places like the Northern Territory, where 40% of the population are Aboriginal or Torres Strait Islander, they are overrepresented in the most disadvantaged strata for that jurisdiction. And 60%, this is an incredible figure, 60% of Aboriginal people in the Northern Territory are in the lowest quintile of socioeconomic position. This is important because your socioeconomic position can drive a whole range of adverse outcomes, particularly mortality, which is a pretty sort of hard and fast outcome. This is data from the US looking at socioeconomic inequality and its interaction with mortality rates over time. In 1977-79, if you were the most disadvantaged, your chances of dying were almost twofold. You see in successive waves of looking at this same data, you can see that this gap is in fact widening. The gaps between the have and have-nots continue to drive poor outcomes. What do we know about income disparity and mortality in Aboriginal people? Not a lot. We do know if we look at quintiles and the gradient in adverse outcomes, this is for 25 to 64-year-olds, in the Australian population there's a very clear linear relationship, and then you throw Aboriginal and Torres Strait Islander people mortality rates in there and it's something completely out of the stratosphere. What is Australia doing in terms of equality and equity in this country? Well, not a lot. In fact, current mantra would dictate that Some governments have tried to reduce inequalities, but they always fail. We've moved on. It's up to individuals to accept their personal responsibility for their lives and their destiny. It's very easy to say for somebody who doesn't live in poverty. When we look at what the last budget was, it's very easy to see who's contributing to making a difference to reduce the gap in the budget hole. This is one of my primary sources of information, Twitter. You can see here, fantastic slide, well put together. Who's doing the heavy lifting in terms of closing the budget hole? It's all of the disadvantaged, when big companies, big CO2 emitters are getting a pretty good ride. So if you are feeling sad and depressed, you might be suffering from capitalism. Grand Challenge 4, global degradation. I put this slide up just as a window into an issue. This is an eye of the faith slide. You have to give me a little bit of leverage on this. But if you look here, the major extraction fronts for mining and other resource depletion in this world just happens to be where there's a whole bunch of Aboriginal and Torres Strait Islander and other Indigenous populations. It's by no means a coincidence. And unfortunately, Australia has a pretty poor approach to what its climate change policy might be. Yeah, I'll just leave that one there. This is a shame. This is not only a shame, this is an absolute travesty. The reason being, if you wanted to know how to care for this country, why wouldn't you ask an Aboriginal person or another Indigenous person? This is a great slide. Ask me anything about this place. Yeah, you know where you're going to live, mate. This is a terrible reality in an issue that will have ramifications for our children and our ancestors for years to come. We are not learning from what Aboriginal people know about this place. And this is important. Land is really important to people, Aboriginal people. We talk about it all the time. It's not a political agenda. It's not a financial agenda. It's a very personal agenda because people are connected to land in such a way as to make the very essence of place the very essence of you. When Aboriginal people meet, they always say, where are you from? Where's your country? This is important because land is your family. It's incorporated into the well-being of you from day one. So if your land is sick, you're sick. And I know it's very hard for biomedical researchers to understand this, but it's an important point to make nonetheless. We incorporate land into the very essence of ourselves. It is our being, it is our life. If it's impaired in any way, it has very real consequences for us. This is why Aboriginal people are obsessed with talking about land. Because land is your family. These are the fundamental underlying principles that guide Aboriginal people's life. This is from South Australia. Chukurpa, the law, what guides you in your life. Walcha, your family. But as I mentioned, it's not just human family, it's also the landscape around you. Nora, your land, your home, your place. And Kanyini, this term which means to care, which fundamentally binds these things together. These are the essence that guides Aboriginal ways of life. These are the fundamental targets for the way in which governments have changed the rules for Aboriginal people to engage with mainstream society. These have been the targets and the consequences have been catastrophic. The other challenge is we haven't really got it right in terms of what our policy response to Aboriginal matters is. We do have a Prime Minister for Indigenous Affairs, but everyone else has taken the day off sick. So what's our Grand Challenge 5? How do you build better healthcare systems? Surely, in developing community contexts and developing population dynamics, really good access to high quality, efficient, equitable care can make a fundamental difference in closing gaps in life expectancies. This is not the be-all and end-all, but it's a very important starting point. If you can get health systems right, you can close a gap very quickly to a certain extent. What do we know about healthcare in Australia? We know, well, it's really got its challenges. What we don't talk about anywhere near enough is the culture of healthcare systems. We always talk about the culture of patients and the fact that the culture of this patient means that they don't listen to what I have to say. This is a very important narrative that plays out in Aboriginal affairs in this country. But we rarely turn the lens back on the system. We very rarely look at the system and say, don't you realise the way you operate has its own cultural context and this is not necessarily conducive to care The other thing we're seeing more increasingly in chronic disease care is that patients are being pains. They're really in the way of you having a nice day in the clinic. This is fundamentally a change from when even I began in a medical career, that care was everything and systems were the things that you fought against most ruthlessly. This has changed. The systems have evolved in a way that protects the needs of finance and not the needs of patients. We have to turn this around. What's our response to chronic disease? We just throw a couple more pills at it. We use fear and loathing as our only scalpel. It's all we've got in our toolkit. We try and scare our patients with mathematical equations of their risk of developing some hypothetical adverse outcome which they can't grasp, they can't make sense of. We'll say you have a 10% chance of having a cardiac event in the next 10 years if you don't do this, that or the other. And you've lost the patient at the first percentage. They don't really know what you're talking about. They don't really understand what that risk is. For them, it's 1 or 0. We have a system that uses fear and loathing at the expense of developing better care systems for the future. Chronic disease, as I mentioned before, is not only our grand challenge, it's the game changer. If we don't morph, if we don't modify the way in which we can build better healthcare systems, we will have lost the race. And chronic disease challenges us as healthcare systems about how we do business. It's important that we focus not on sickness but on wellness. At the moment, we talk about chronic disease risk as a consequence of bad people making bad choices. We have to move beyond this. We have to move beyond using fear and risk as our only tool, and we have to focus on lifelong engagement and relationships between patients and providers, families and communities, and invest in functioning systems. These will be the things that we need to build, and these are the very things that Aboriginal people are asking for. When we ask them what would work, they say, we just want systems that work better. We want you to get out of your clinics. We want you to spend time with us and our family. We want information in our hands to make our own decisions about our future choices in healthcare. The system is extremely fragmented. You have to help us make it through. You need to integrate care across all of the continuum. You can't have all of these silos in primary, tertiary, and other care arrangements. But fundamentally, we want to be treated with respect. We want you to invest in relationships with us, and we want to be treated with humanness. Now, these are fundamentally not too much to ask. This is the system that we should invest in. This is the future that we should all be buying into. So what are we doing about it? Well, we'll just touch on a couple of things. We started by asking Aboriginal people how to understand things like type 2 diabetes. This is what they said. Well, if you look at a medical view of type 2 diabetes, and this is changing but slowly, it's about bad people, bad choices, bad behaviours, lazy individuals who are too fat and too silly to do anything different. If you talk to Aboriginal people about what causes type 2 diabetes, they talk about dispossession, of disharmony and imbalance in their lives, of their exposure to poverty and disadvantage and what impact it has on them in their lives. They talk about change to the lives that they lead day in, day out. They talk about not being able to access the things most important to them, their land, their families. They talk about toxic external pressures, and all of these are building up, particularly in the context of transgenerational trauma that plays out in successive generations. These are the causes of diabetes in an Aboriginal narrative. And you know what? If you look at the emerging literature across a whole range of paradigms of research, you might start to think that Aboriginal people might be onto something. We've also spent time thinking about why Aboriginal people are stuck in a delayed transitional phase between infectious disease and chronic disease as the primary cause of death. And that's because they are exposed to a whole range of things that change the dynamic of the way in which Aboriginal people interacted with mainstream, interacted with life, interacted with the communities in which they were often forced to habitate in. Their whole societal structure was reorganised. The way they did things was changed comprehensively. There was congregation. People from many places were put into single encampments or single missions, and these were people who had never spent time together because they were able to preserve each other's integrity and sovereignty on their own lands for generations before. There were significant nutritional impacts in what the diet for Aboriginal and Torres Strait Islander people were through contact. There was cultural reorientation. People weren't allowed to speak their language, weren't allowed to experience generations of wisdom passed down from grandparents to grandchildren. And these all had significant improvements for bacteria, who we all know are extremely intelligent beasts, but it also had enormous psychological impacts. This is why we see increasing chronic disease burden, but not falling infectious disease burden. We're certainly seeing falling infectious disease mortality, but we have still ongoing extremely high rates. What are we interested in? We're also interested in this nexus between the three amigos, the unholy trinity of vascular risk we see in Aboriginal people. High rates of atherosclerotic disease, high rates of insulin-resistant and type 2 diabetes, and high rates of CKD. What drives this? What's happening? How can we use what we know about phenotypes to understand what could possibly be driving this interaction between chronic disease comorbidity profiles? We see more comorbidity in this population than any other population or any other model that you could care to name. We have, unashamedly, a very strong focus on primary care research. We began by trying to understand how the system worked, how we identify and manage risk, how Aboriginal people understand their experience of chronic disease and how to build better care systems of care. How do we make chronic disease care and primary care easier? We moved into the second phase of that work, focusing on the development of models of chronic care from an Aboriginal perspective, our particular focus and interest on depression and chronic disease in primary care, and about models of service delivery that can take the next step out of clinics into communities through case management. What the community has now asked of us is that we focus on the next generation, that we're building resilience, and we have a functional, sustainable system of care moving forward that they want us to work on. So none of this has come from how clever we are. All of this has come from what the community has demanded of us in our work and our health systems research. Similarly, we have a very strong focus around knowledge translation. Again, this is primary care focused. This is a national piece of work with the National Aboriginal Community Controlled Health Organisation and also the jurisdictional reference groups in every jurisdiction in this country, focusing on pulling together the evidence as we know, providing guidance to primary care, implementing and then evaluating what we do. And what they're saying to us is we need to be focusing on our governance, our accreditation, our quality improvement. We need to define our own outcomes as Aboriginal people. We need a sustainable workforce, sustainable funding models, and a focus on best practice care. This is a pretty good model for developing any primary care response anywhere in the world for chronic disease, and this has come from Aboriginal people. We're also working on models of care with nurse-led and Aboriginal health worker-led models of care for patients after they have a heart attack. We work with them in the family, in their community, and provide outreach, rehabilitation, support and education. And this is a painting from one of the community members who liked the idea so much she said, well, I'll paint this story for you. That's what it is. We're trialling ranges of things, particularly focusing on information technology. Can we use information technology to improve outcomes? We have a teleretinal imaging program run in the Northern Territory, 600 patients with diabetes. We're focusing on supporting healthcare systems, supporting health practitioners, and supporting patients to get better outcomes in care. And this we'll be reporting on in the next 18 months. Our focus on psychosocial stress and really getting under the skin of socioeconomic disadvantage and stress and worry is really framed around this. What is the impact of chronic psychosocial stress on body, mind and spirit? What are the unifiers or connectors that operate across each of these elements? How, if understanding that, can we use that to mitigate the pathways to cardiometabolic and adverse outcomes? And how do we mitigate, manage and prevent to make a difference for these people's lives? Similarly, in the cancer front, given the data I showed earlier, are really about the rise of cancer mortality in Aboriginal people. What we're hoping to do is really develop better registry systems, epidemiological data systems for cancer, to be able to link all data across the country. This is an enormous frustration in this country that we can't get access to what should be publicly available linkage data. We spend about 60% of our time and staff resources waiting for data custodians to say yes. But what we're trying to add to this real-time data system is experience, the patient's experience of the cancer care journey. This is extremely ethically challenging. It is sensitive. It's hard to have conversations with families when they're going through what is probably the most challenging time of their lives. But if we can do this, we can then build a real-time cancer monitoring and surveillance system from both an epidemiological and interpersonal perspective, and hopefully improve care over time. The last bit of work we're doing is really focusing on government policy. How do you close the gap? They talk about it all the time. It's mantra. There's a bumper sticker. I've probably got a few stickers here and there. I've probably even got a T-shirt. We need to understand what drives those differentials. We also need to understand what gap we're interested in. We feel that a focus on equitable service delivery, the standards of care that every Australian should get, should be a framework to reduce inequalities. We should define those elements. We should see who's getting them. We should make sure we know how best to deliver those services to those who cannot, and we need to actually model what it's going to cost and take to deliver it. So what can you do? Well, this is part of a slide I presented last year, and just in case there's new people in the room, I just added a couple. What can we do in Aboriginal health? It's very hard for people to enter this space. It's very challenging. They don't know how to make a difference. Don't just stand there, do something. Importantly, it's very good for you to know that only the best of the best will be good enough for Aboriginal Australia. We're the most disadvantaged community in this country, and we don't want somebody who's no good. I'm sorry, if you're not good enough, go and work with someone else. We need the absolute best. If you're the best physiotherapist, come on down. If you're the best expert in toenail fungus, I can hook you up with the community who needs support with toenail fungus. And importantly, don't be obsessed with what you can't change, but be driven by what you can. It's very easy to get swamped by the issues facing Aboriginal Australia and think, my God, it's too hard, I don't know what to do. Where are we heading, and where are there things that we should be talking about? Inflammation and chronic disease. This is clearly an important starting point for a range of conversations we could have. Understanding comorbidity, as I touched on. What do we know about the biology of disadvantage? How do we overcome intergenerational risk? But probably the easiest entry point for an institute of this standing and your expertise, you should be training the next generation of Aboriginal scientists. And I think that's the easiest start. It's an important start. And we'd be very, very happy to help in any way we can to see that through. So I'll leave it there. Thanks very much.
Thanks, Alex, for an excellent talk. We've got about 10 minutes for questions while we wait for the mic to come down. Just to start off the questions, I'm really interested about how you've used Indigenous frameworks of health in order to inform health practice. Can you talk about how difficult that process was and how that could be applied to science? That would be quite a difficult ask, but do you think it's possible?
Yeah, thanks for starting off with such an easy question. It's been an extremely long process. I probably established relationships with Aboriginal communities for 6 years before we did any research. We even thought about doing any research. And it was really to establish my credentials. So was I the right sort of person? Did they trust me? Was I willing to contribute? Was I going to make a difference in people's lives? They were the things that I had to work through in the first instance. What we had then was, you see this very important curve that occurs in how much people think they understand about Aboriginal issues when they're first exposed. They start off knowing nothing. Within 12 months, they know absolutely everything. If they stick around for another 5 years, they realise they actually know nothing. So you have to work through that cycle. But what you do when you do that, you'll find that there are enormous possibilities for research and health system reform that you have as an idea. What I did was we took all of those ideas to community. So we had the conversations with elders. The reason that I did my PhD on the links between depression and heart disease was not because I was interested in that. It was because the community said to me, you need to do that work. And so I went and spoke to them. I didn't know how to do that. So I asked them, how am I going to do this? And they said, it's really easy. We've known this for a very long time. And there was a painting that was done by a police aide which laid out the pathophysiological mechanisms linking depression and heart disease in Aboriginal people. And I still use that painting today, and it's stood the test of time. It clearly articulates a whole range of activity around HPA axis activity, autonomic nervous system dysregulation, inflammation, behaviours, you name it, it's covered. You'd be surprised how much people know. You'd be surprised about how much communities know. You'd be surprised about how much wisdom is passed from generation to generation in these long-standing, culturally intact communities. We talked to traditional healers about the link between heart and mind. They're able to very clearly articulate where I should poke my nose and in what direction I should travel. Our work around healthcare systems, well, surely if you're going to build a healthcare system, and that's what we wanted to do, we didn't want to know what the barriers and enablers to care were. We wanted to build a better way. Where do you start? You start with the community and the people experiencing it. We asked Aboriginal people, do you know anyone in your family or your community that has heart disease or diabetes? And they just said, yeah, everyone. Everyone has it. Now, there's not a white community where you could have that same conversation. So they're invested in a better system. They think about it every single day of their lives. They experience the horror and the wonder. They are the important first point for building a better way. So we've done it through respect, we've done it through having time, we've done it through being flexible, but more importantly, we've done it by being humble. It's very hard in science. It's like surgeons. I don't know if there's any surgeons in the room. Surgeons are trained to make a call and back it with everything that they've got. Because it's pretty hard if you're in the middle of a resection to actually say, well, hang on a sec, I'm not sure about this. You can't just knock off a colony and say, well, we'll start again. You're in the middle of an operation. We're trained to make a call and back it. Science is a bit the same. We're trained to sell ourselves with an idea so that we can get funded to do the work. Our idea is more important than everyone else's. What we're doing is more important than anyone. This is a very bad starting point for a conversation with community who expect you to, with great humility, offer yourself up to make a contribution, and they will dictate the nature of that. That's how we've done it. Very long answer, obviously.
Thank you. Are there other questions? Start with Len.
Thanks, Paul. That's very inspiring. Can you say something about food, quality, accessibility? Because arguably it's at the root of the problem. I mean, too much pro-inflammatory food. I mean, if we ate less, then a lot of these problems would go away, particularly certain foods. And my observation is that the Aboriginal communities don't have access to the right food.
Yeah, that's absolutely right. I mean, there's been significant information put together, particularly by Karen O'Day over a number of years and a lot of her postdocs. Food accessibility and affordability is a major problem in this country. There is no appetite for thinking through from a policy response how to get on top of this. Most people who live in poverty will make important choices about how far they can make their dollars go. If you've got limited money, you buy stuff that's probably the worst for you. It's the highest density of calorie. It usually is the least healthful type of food, but you choose it because it'll get you through for 3 days when you don't have anything to eat. So people do that. People's choices are bad, but people's accessibility of good quality food is perversely incentivised around the wrong way. So a tomato in a remote community will cost you $2. A pie will cost you 50 cents. What are you going to buy? And the tomato's probably rotten and squashed and completely inedible anyway. So we've really not tackled this challenge. And you would think that in a country like Australia that can do a whole bunch of stuff, we still can't get the logistics right to deliver healthy, affordable food to all Australians. I mean, it just beggars belief. We've got a long way to go.
Alex, as an outsider, I sort of wonder, I mean, I see the importance of passing down wisdom from the generations, and I also see that, you know, over the last couple of generations that resource has been severely depleted. And so I guess my question is anything being done to try and redress that, and what sort of programs can you institute to try and preserve what you can at this stage?
Yeah, so there's quite a lot of cultural reclamation going on in this country. There's There are, every year there are probably 10 or 15 Aboriginal languages in this country alone that are threatened and being lost. So there's a reclamation movement to recount and collate all of those languages. There's a very strong art movement. There's a very strong media movement and communications movement, which is recording a whole bunch of the stories from an Aboriginal perspective now that hasn't happened before. Most of the great collections of anthropological musings in this country have not been from Aboriginal people. They've been from non-Aboriginal people, usually in the sort of early to mid-1900s. That's really changing. Aboriginal people are reclaiming that space and recording the stories of their grandparents. The other way we can do it is by science and health systems and social sciences recording these stories and these learnings and infusing it into the way we do business. But we've got nothing to lose. And that's what we're trying to do.
Are you happy there's enough being done in that space?
Oh, I wouldn't think there's enough being done. But that's not my path. I mean, we can all make a contribution that we can make. So my contribution is to try and convince the smartest brains in this country to make a contribution to Aboriginal health. That's part of my ongoing commitment to the legacy that we want to see a better future for Aboriginal people. So I could spend all my time writing stuff down, which would be really important to do, or I could spend my time talking to you guys and saying, you know, if I get 2 people out of this room who are going to ante up and make a difference to Aboriginal people through what they know about science, that's a good day.
Question at the back.
You focused on the deficit model of Aboriginal health. In the spirit of Mandalay Unifinger's two-way learning, I wonder what lessons Indigenous culture, learning and ways of knowing can have for medicine and medical research.
Well, thank you for that input. I thought that I was focusing on what Aboriginal people could offer in terms of their understandings of these very complex realities. I think the strength-based approach around caring for country and understanding the land on which we are is one way that we can offer that. I think understanding the impact of intergenerational disadvantage. Aboriginal people are obsessed with generational support, nurturing and care. And I think that's an important thing. I think Aboriginal people are obsessed with connectedness, and that's what we're losing as mainstream Australian society. I think they understand that there's no separation between the social, the physical, the emotional, and the spiritual. These are all interconnected parts of human realities. These are universals. I think we're losing, and we've lost sight on that in the last sort of century of our very structured approach to unpacking human existence. I think Aboriginal people can offer all of that. And this sense of great humility that Aboriginal people have is something that we can all learn from. And I hope that one day we all will. So I think there's a lot that Aboriginal people can offer, and I'm sorry if that didn't quite come across. I do put forward lots of data that is challenging and distressing and worrying and negative. But that's an important part of my job, to tell people what it's really like, because it's very easy for mainstream Australia not to know what's going on really here. The challenge is to get that balance right. So thanks for that point.
I think we have time for a question from Misty.
Yes, thank you. That was fabulous. Thank you so much. I found that really moving. But as I was a Wurundjeri woman myself and as a scientist, I know there's not many of us in the country, I'm interested in sort of historically in the 1990s with the Human Genome Diversity Project, which was done the Vampire Project. Indigenous people were studied and sort of became subjects, I guess. And you know, that a lot of Indigenous people think that has implications for race typing and you know, potentially even impacting native title, for example. But so I guess, you know, and I've just recently come back from a trip to the Kimberley, been out to some of these really remote communities where just food is an issue and just basic public health is an issue. I guess my question is, how do we overcome that hesitation now to be involved? What advice would you give to this group of very clever scientists who do want to help make a difference and they don't want to just stand there and do something? I just also recently sat on the Indigenous panel for NHMRC, and I saw grants fall over because they were scientifically brilliant, but they didn't have Indigenous engagement with communities. What advice would you give to scientists? How do scientists overcome that barrier to make a difference? And so I know it's a hard question to answer, but in terms of building those community links and engagement.
Yeah, so I'll start with that point and we'll get to genomics at the end, because we've probably got 2 minutes. How do you make a connection with Aboriginal people and Aboriginal communities? Well, there's all sorts of ways. Probably the most important is through somebody you know who can vouch for you. This is how it all happens. Everything's relationship based in Aboriginal communities. If people say it's something else, it's not. It all starts with a relationship. So if you know somebody who knows somebody and they can vouch for you, that's usually the best and most important entry point into an Aboriginal community. You then got to do your apprenticeship. Now that need not be 6 years, like actually I'm still serving my apprenticeship and I haven't passed yet because I keep moving and I have to start again. But we connect with people on a very human level and try to offer something that the community needs or ask them what they need and deliver it. The classic example is I was running the Centre for Disease Control in Alice Springs. We had an outbreak of tuberculosis in a community, a remote community, 8 hours from Alice Springs by road. I went down to that community and said, we've got a TB outbreak, we need to do something. And they said, we need a dog program. I went, oh God, how am I going to get a dog program? But I got them a dog program. 3 weeks later, dog program was done. I went down there and said, we've got a TB problem. They said, yep, what do you need? You know, you've got to offer something. The other way is through people who have relationships and connections. This puts an enormous pressure on those individuals as conduits, but it's an important entry point. We offer that brokerage service. There's other places that offer these brokerage sorts of services. It's not a service per se, it's a relationship-based approach to making a difference in Aboriginal people's lives. So there are people who can connect you, and that's how it really works better than anything else. The last question about genomics is a really important one. There are such social disparities at play in Aboriginal communities that even if there are genetic issues at play or causation to be assumed from what we could learn from genomics, there are still some fundamental social realities that we need to deal with. Now, this doesn't mean that genomics is not going to land slap bang in the middle of Aboriginal people's lives already, and it's started. Whether we like it or not, genomics is coming to Aboriginal Australia, and we need a response. The reality is it has to be Aboriginal-led, and there's no reason to fear that. It doesn't have to be, the science is led by Aboriginal people. The governance, the custodianship, the terms of engagement, the agreements around IP sharing, the relationships that we have with those samples and understanding about what their significance is from a cultural lens as well as a scientific lens is a negotiated space, and we should start with those negotiations. There are some guidelines or frameworks in the mix at the moment which we'll share with you guys. This is coming. There are grants that would have been on the table this year and the last few years where genomics is going to be a part of the Aboriginal research landscape. It's not dangerous work, it's just challenging in terms of the ethic, the moral and the process. We need to get that right together, and there's lots of people in this country who can provide that support and advice. Thanks, Missy.
If you could just scroll a bit.